Good morning, everyone. Myself, Shreyansi Patel, tutor from Faculty of Physiotherapy. Today's topic of presentation is Biomechanics of SI Joint. This is the sacroiliac region, sacrum location located by the orange color. Structure of the sacral region. Five sacral vertebrae are fused to form the triangular or wedge-shaped structure that is called the sacrum. The base of the triangular, which is formed by the first sacral vertebra, support two articular facets that face posteriorly for articulation with the inferior facet of the fifth lumbar vertebra. The apex of the triangle formed by the fifth sacral vertebra articulation with the coccyx. The lateral part of the sacrum or ala bears an articular ear-shaped surface that articulation with the ilium. The ala also bears the sacral tuberosity that is posterior to the articular surface and articulates with the iliac tuberosity. What is the role of SI joint? Role of SI joint is to relieve the stress on the pelvic ring imparted by movement of the trunk and lower limbs, muscle contraction, the weight of the body and ground reaction forces. The joint must allow movement to absorb the twisting force ascending from the lower limb yet be stable enough to transmit the force from the vertebral column descending to the lower limbs. Stable means for transfer of load between axial skeletal and lower extremities. Factor providing stability. Stability is primary requirement of joint maintained by interlocking of articular surface, thick and strong interosseous and posterior sacroiliac ligaments, vertebropelvic ligaments. Sacroiliac articulations. The sacroiliac joints are weight-bearing compound joint consisting of an anterior synovial joint between the auricular surface of the sacrum and ilium and a posterior syndesmosis between the tuberosity of the same bone. Articulating surfaces on the sacrum. Articulating surfaces ear shape on the sacrum are located on the side of the fused sacral vertebra lateral to the sacral foramina from S1 to S3. The fetal and prepubertal surfaces are flat and smooth, while the postpubertal surfaces are marked by a central groove or surface depression that extend the length of the articulating surfaces. The articular surfaces are covered with hyaline cartilage. The thickness of the sacral cartilage 1 to 3 mm, which greater than iliac cartilage. The tuberosity is an irregular bony surface posterior to the articular surface that articulates with the tuberosity of the ilium. Articulating surfaces on the iliac. The articulating surfaces on the ilia are covered with hyaline cartilage, although the hyaline of the ilia contains a denser aggregate of collagen fiber than that of the sacrum and is less than 1 mm thick. The articular surfaces of the ilia are also multiplanar and curvy to match those of the sacrum. The fetal and prepubertal articular faces of the ilia are flat and smooth, while the postpubertal surfaces develop a central ridge that extend the length of the articulating surface and correspond to the grooves on the sacral articulating surfaces. The, the tuberosity of the ilia is an irregular bony surface posterior and superior to the auricular surface that articulates with the tuberosity of the sacrum via the sacroiliac interosseous ligament. Sacroiliac ligaments. The anterior, posterior or dorsal and interosseous sacroiliac ligaments are directly associated with the sacroiliac joints. The anterior sacroiliac ligaments are considered to be capsular ligaments because of their intimate connection to the anterior inferior margin of the joint capsules. According to Bogduk, the anterior sacroiliac ligaments cover the anterior aspect of the sacroiliac joints and join the ilia to the sacrum. A separate portion of the posterior sacroiliac ligament is called either the long posterior sacroiliac ligament or the long dorsal sacroiliac ligament. The paired long posterior or dorsal sacroiliac ligaments have superior attachment to the posterior superior iliac spines and adjacent part of the ilium. Inferiorly, the ligaments are attached to the lateral crest of the third and fourth sacral segment. The medial fiber are connected to the deep lamina of the posterior layer of the thoracolumbar fascia and the aponeurosis of the erector spine. This is the anterior view for different ligaments. The interosseous sacroiliac ligaments, which constitute the major bonds between the sacrum and the ilia, are considered to be the most important ligaments directly associated with the sacroiliac joints. These ligaments create the more posterior syndesmosis between the tuberosities of the sacrum and ilia. The sacrospinaeus ligaments connect the ischial spine to the lateral border of the sacrum and coccyx. The sacrospinaeus ligament form the inferior border of the greater sciatica notch. The sacrotuberous ligament connect the ischial tuberosities to the posterior spine at the ilia and the lateral sacrum and coccyx. The sacrotuberous ligament form the inferior border of lesser sciatica notch. The iliolumbar ligaments, which connect the fifth lumbar vertebra to the ilium, the sacrospinaeus ligament, and the sacrotuberous ligament, which connect the sacrum to the ischium, are indirectly associated with the sacroiliac joints. The sacroiliac ligaments are reinforced by fibrous expansions from the quadratum lumborum, erector spinae, gluteal maximus, gluteal minimus, piriformis, and iliacus muscles, which contribute to the joint stability. The facial support is greater posterior than anterior because more muscles are located posteriorly. Symphysis pubis articulation. The symphysis pubis is cartilaginous joint located between the two ends of the pubic bones. The end of each pubic bone is covered with a layer of articular cartilage and the joint is formed by a fibrocartilaginous disc that joins the hyaline cartilage covered end of the bones. The disc has a thin central cleft which in women may extend throughout the length of the disc. The three ligaments that are associated with the joint are the superior pubic ligament, the inferior pubic ligament, and the posterior ligament. The superior ligament is a thick and dense fibrous band that attach to the pubic crest and tubercles and help support the superior aspect of the joint. The inferior ligament arches from the inferior rami on one side of the joint to the inferior portion of the rami on the other side and thus reinforce the inferior aspect of the joint. The posterior ligament consists of fibrous membrane that is continuous with the periosteum of the pubic bone. The anterior portion of the joint is reinforced by aponeurotic expansion from a number of muscles that cross the joint. Appendix G describes the muscle expansion as forming an anterior ligament consisting of expansion of the transverse abdominis, rectus abdominis, internal obliquus abdominis, and adductor longus. Kinematics. The sacroiliac joint do permit motion but only in extremely small amount. Although small in quantity, this motion is important for attenuating the forces transmitted via the pelvis ring to prevent sacral fracture. Rotational motion 0.2 to 2 degree, transitional motion 1 to 2 mm. Range of motion increase during pregnancy in which all ligaments of pelvis become loosened under influence of hormones to facilitate delivery of fetus. The motion that does occur at the sacroiliac joint is typically described as symmetrically or asymmetrically. Symmetrically motion is the movement of both innominate bones together as a unit in same direction in relation to the sacrum. Asymmetrical motion is movement of the innominate bones in opposite directions because of the close kinematic chain with the pubic symphysis. Any asymmetrical motion at the sacroiliac joint result in motion at the pubic symphysis as well. Symmetrical motion at the sacroiliac joints can be described by naming the motion according to the sacral movements or according to the innominate movement. First one is a nutation, is a term commonly used to refer to movement of the sacrum whereby the sacral promontory moves anteriorly and inferiorly, while the sacral apex moves posteriorly and superiorly. During the closed chain task of forward bending from standing position, for example, the sacrum will nutate on the two innominate bones immediately following flexion of the lumbosacral junction. This is the sacral nutation. Counter nutation refers to the opposite movement in which the sacral promontory moves posteriorly and superiorly while the sacral apex moves anteriorly and inferiorly. Nutation and counter nutation. Nutation, movement of sacral promontory anteriorly and inferiorly. Counter nutation, anteriorly tip of sacral promontory moves posteriorly and superiorly. Nutation, posterior ilium on sacrum rotation. In counter nutation, anterior ilium on sacrum rotation. In nutation, coccyx moves posteriorly in relation to ilium. Counter nutation, coccyx moves anteriorly in relation to ilium. In nutation, and AP diameter of pelvic brim is decreased. In counter nutation, AP diameter of pelvic brim is increased. In nutation, AP diameter of pelvic outlet is increased. In counter nutation, AP diameter of pelvic outlet is decreased. SIGS and symphysis pubis are closely linked functionally to hip joint, affects and get affected by movements of trunk and lower extremities, hip flexion in supine position, posterior tilting of ilium, nutation at SIGS, increased diameter of pelvic outlet, facilitate delivery of fetal head. Hip flexion in supine, anterior tilting of ilium, counter nutation at SIGS, increased diameter of pelvic brim and descendant of fetal head in a pelvis. Hip flex position is used during delivery. Anterior pelvic tilt is the term used to refer to the symmetrical movement of the innominate bones whereby the anterior superior iliac spine and the pubic symphysis moves inferiorly. During the open chain task of bilateral hip extension in prone, for example, anterior pelvic tilt of the two innominate bones will occur on the sacrum immediately following maximum hip extension. In posterior pelvic tilt is the term commonly used to refer to the symmetrical movement of the innominate bones whereby the anterior superior iliac spines and the pubic symphysis move superiorly. Symmetrical motion at the sacroiliac joint is described as a pelvic torsion of the innominates on the sacrum. Asymmetrical motion occurs during asymmetrical tasks such as ambulation in which one hip is in a flex position while the opposite hip is in an extended position. First one is neutral, second one is posterior pelvic tilt and third one is anterior pelvic tilt. The innominate on the side of the hip flexion will be torsionate in a posterior direction while the innominate on the side of the hip extension will be torsionate is in an anterior direction. Pelvic torsions are always accompanied by motion at the pubic symphysis. Movement of ilium, posterior rotation, anterior rotation, motion of innominate relative to sacrum occur at a coronal axis. Anterior rotation occurs during extension of the freely swing. Posterior rotation in single leg standing, both weight bearing and non weight bearing innominants posteriorly rotate relative to sacrum, which is relatively neutered. Sacroiliac joint is thus in close pec position. It's also associated with side flexion of pelvis, non-weight bearing innominants anterior superior relative to the sacrum, weight bearing side posterior and superior relative to the sacrum. Kinetics. Stability of the sacroiliac joint is extremely important because these joints must support a large portion of the body weight. In normal erect posture, the weight of the head, arm, and trunk is transmitted through the fifth lumbar vertebra and lumbosacral disc to the first sacral segments. Three stabilizing forces at SI joint: gravity, stretch ligaments, muscle tension. Muscles that reinforce and stabilize SI joint: erector spinae, lumbar multifidus, and abdominal muscles, external and internal obliques, rectus abdominis, transverse abdominis, and hamstrings such as a biceps femoris. First one is a gravity, second one is a stretch ligament, and third one is the active muscle force. The force of the body weight create a nutation torque on the sacrum. Concomitantly, the ground reaction force creates a posterior tilt of the innominate. The counter torque of the nutation of the sacrum and posterior tilt of the innominate are supported by the ligamentous tension and fibrosis expansion from adjacent muscles, which reinforce the joint capsules and blend with the ligaments. Iliolumbar ligaments have a significant role in stabilizing the sacroiliac joints as well as the lumbosacral junction. The ventral band of the iliolumbar ligament is of particular importance in restricting sagittal plane sacroiliac joint mobility. Also, tension develop in the tuberous, sacrospinous, and anterior sacroiliac ligaments counteracts the nutation torque of the sacrum. Although the sacrotuberous and sacrospinous ligaments have not been found to play a major role in a pelvic stability. The sacrotuberous and interosseous ligaments compress the sacroiliac joint during nutation. The long posterior or dorsal sacroiliac ligament is under tension in counter nutation and relaxed in a nutation. The interosseous sacroiliac ligament binds the ilia to the sacrum. Shearing force are created at the sacroiliac joints and symphysis pubis during single leg support activities as a result of lateral pelvic tilting. Under normal circumstances, the joints are capable of resisting the shearing forces and no appreciable motion occurs. If, however, the pubic symphysis is dislocated, the pelvis becomes unstable during gait with increased stress on the sacroiliac and hip joints as well as the vertebral column. The complementary ridges and depressions that develop in the cartilage of the sacral and iliac surfaces also contribute to the stability of the joint. Vertical load bearing is facilitated by the development of these ridges and depressions, but motion is limited by them. Thank you.